Can I throw a grenade on the table? Persistence, adherence, lack of follow-up, our fault. Our fault.
No.
I mean, it's very tempting to blame patients, but if you're not calling them, you're not using physician extenders, you're not getting people out in the community, bring these patients back. Yes, there are going to be some patients who don't, but isn't that really our fault?
But the system
Both
is
sides.
changing. You're actually now maybe going to be paid for coordination of care, which requires those phone calls and other things like that and following up.
So yeah, I kind of getting back to that clinical inertia issue,
That's
which
what I'm trying to get
I
to,
know,
yeah.
that's where we were really talking.
Right.
The issues are multiple, and I think Vivian really addressed something that hopefully is going to change. If you're seeing a patient who is not bringing in glucose testing, and you don't have their A1C from the last week or month, how are you going to make that decision on what to do with that patient? So you send them to the lab, they go get their A1C, and then you get it back, and you don't even have the opportunity to see the patient, to talk to them about it. And so it's typically going to happen, the letter goes out, your A1C is high, try to be better with your diet and exercise, and we'll talk about it next time, and the next time is just a repeat of the same. So having the appropriate data at the time you see the patient so that you can have that conversation. And that's something that a lot of docs don't, or providers in general don't do, is to plan their visits and to use their staff to make sure that they have all the information they need for appropriate management of
That's
that
what I
patient
was
at the
getting
moment.
at. That's
Yes.
exactly what I was
Coordination of care.
getting at. Coordination of care. That's part of inertia. If you don't have that, you don't get things done.
The difficulty is that the majority, as you know, the majority of patients, diabetic patients with diabetes, are taken care of by primary care providers who often don't have the resources to share it with a nurse or an educator or someone who can help them. And often, they're out there by themselves in a 10-minute interview or seeing the patient, and then they spend 20 minutes writing the note that they have to do.
So I will tell you that an MA can take on a lot of responsibility of knowing if the patient's coming in and making sure that the tests are order the tests if they're not ordered, do the foot exam when they come in, counsel the patient on goals. You can do this in a primary care office, but you have to change the system. You have to change actually how you deliver care.
It needs a pretty big change because even just administration of insulin to teach somebody how to administer insulin takes about 20 minutes to go over, and then they need to go over again and again and again.
But it is amazing how, we need to give him credit to the primary care physicians. There's no question that, those guys are smarter than us because we only do diabetes. These guys do everything. And
They see everybody who walks
everybody who comes, and there's competing needs. So people come, and they don't come just for the diabetes. They come for this problem, they come for asthma, they come for skin rash, they come all sorts of things. And there, they need to get it. But one of the things, Bob Henry was saying that things have changed in 1995, major change when metformin came. The other major change is when basal insulin glargine came in 2000. Actually, the primary care physicians are doing very well starting people on basal insulin because we kept it simple.
Simple.
So I don't want to hammer on primary care. I think that your point is well taken, right? Which is everything comes flooding through that door. But by the same token, diabetes is bad. Diabetes is everywhere. It's a pervasive disease. So to some degree, is it your responsibility as thought leaders in this profession to give them an easier pathway? And that's the problem?
No, I do think that's important. I think Carol's saying that. She's saying that if you can, we should do everything we can to make it simpler and easier and to train as many people as we can. This is not a one-person show. Treating people with diabetes is not just for the physician or the PA or the NP. It really is a team as much as possible, even if you have to get your assistant to help you, who may not
Absolutely.
be medically trained.
But you can train them to do a lot of what the patient needs to do.
Right. Body weight,
and to make
skin
sure that they
care,
organize
foot care.
for you so you have everything you need. And probably one of the most important things that I think primary care docs can do to take better care of their patients with diabetes is to plan a diabetes-specific visit. This is your diabetes visit. Oh, doc, I have back pain. Okay, we can handle your back pain or your diabetes. If we do your back pain, you're coming back for your diabetes, and not let the patient's other priorities take over what is supposed to be a visit focused on diabetes.
Will third-party payers cover 2 visits?
Yes, because you're seeing diabetes and you're seeing back pain. You just need a diagnosis.
Okay, so at least we've got some pathway here. some advice you can give these, I'm not being facetious, overworked, underfunded primary care physicians who see the whole community. Absolutely. But I don't want to lose sight of the fact that diabetes is big and pervasive and potentially lethal. So it's a big problem.